to meeting number 8 of the Standing Committee on Science and Research. Pursuant to the motion of the House on June 18, 2025, the committee is meeting to study antimicrobial resistance. Today's meeting is taking place in a hybrid format. Pursuant to the standing orders, members are attending in person in the room and remotely using the Zoom application. Before we continue, I would ask all in-person participants to consult the guidelines written on the cards on the table. These measures are in place to help prevent the audio and feedback incidents and to protect the health and safety of all participants, including the interpreters. You will also notice a QR code on the card which links to a short awareness video. I would like to make few comments for the benefit of witnesses as well as all the members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic and please mute yourself when you are not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raise hand function. The clerk and I will manage the speaking order as best we can, and we appreciate your patience and understanding in this regard. I would like to welcome our witnesses for today. For the first panel, we are joined by Dr. Victor Leong, physician, by the video conference. Dr. Leong, welcome. Dr. Alison McGeer, professor from the Department of Laboratory Medicine and Pathobiology, University of Toronto. And our third witness is Dr. Simon Otto, associate professor, University of Alberta, by video conference. So we will start with Dr. Leong. All the witnesses will have 5 minutes for their opening remarks. And Dr. Leong, you can go ahead. You will have 5 minutes for your opening remarks.
Thank you, Madam Chair. My name is Victor Leong. I practice as an infectious diseases physician and microbiologist in Vancouver, and I've been in practice since 2011. On a daily basis, I treat infections, and what's becoming increasingly clear is that infections that we encounter commonly in hospital are increasingly becoming resistant to antimicrobials that we have available in Canada. And I'm sure, as you've heard from other witnesses so far, we need to urgently examine the barriers that are preventing access to antimicrobials in the Canadian market and change that process. Now, when it comes to access to antimicrobials, we know that Canada, compared to other G7 countries, is falling behind. We don't have thoughtful programs that are well designed, examples that have been piloted in other G7 countries. And what we need is programs that ensure patients get the drugs when they need it at the right time while maintaining those stewardship practices. So in Canada, when we encounter a difficult to treat pathogen, we often rely on Health Canada's Special Access Program. But from my experience working with the Special Access Program, there is excessive administrative burden, paperwork that needs to be modernized, and the whole system within special access needs to be revamped so that patients can get the antimicrobials when they need them. I think a solution that needs to be implemented has to be coordinated between the federal and provincial governments. One example would be the hub and spoke model that has been discussed previously. We're having high-value antimicrobials be available in centers, similar to how we deal with some antimicrobials for treating malaria. And I think the federal government has to play a central role in guaranteeing that these drugs become available to the market, while also having accountable systems to ensure that these antimicrobials are not overused. And in Canada, among the different provinces that are involved, there needs to be equal access because of mobility. Antimicrobial resistance will not stay local, and changes can happen rapidly. Unlike other drugs, depending on the condition, if individuals present with sepsis, septic shock, timely access is key. Now, in addition to access, which is really about controlling infections, we have to do a lot more in preventing infections. Antimicrobial resistance can and needs to be prevented using the tools that we have, but they need to be done in a different way. So 2 examples that I'd like to bring up are surveillance systems in Canada for antimicrobial resistance. Although we have multiple surveillance systems throughout Canada that are used, the problem is that the information is fragmented. It's not utilizing the information that's available from all different settings to be aggregated in a way that's timely. Perfect example of that would be for some of the infections that we have surveillance for in hospitals. If we look at the Canadian Nosocomial Infection Surveillance Program, the data reports that are provided are out of date and they're not timely and accessible so that we can plan and develop programs to prevent these infections and monitoring the effectiveness of these programs for accountability. A second example of that would be for prevention is looking at how we develop processes that are innovative. And in Canada, we have solutions for that. Drawing upon our success previously with controlling HIV and the treatment as prevention approach, we can see that when treatment as prevention as a program is implemented to address different endemics like homelessness, opioid use, antimicrobial resistance, that can have an impact on targeted disease elimination and healthcare sustainability. So we need to focus not only on control through drug access, but also on prevention of antimicrobial resistance through modernizing the surveillance systems and modernizing and expanding proven Canadian interventions that have been shown to work. And those need to be implemented more broadly for both communicable diseases and also can be applicable to non-communicable disease. Thank you.
Thank you, Dr. Long. Now we will proceed to Dr. Alison McGeer. You will have 5 minutes for your opening remarks. Dr. McGeer, please go ahead.
Thank you very much, Madam Chair, for the opportunity to testify. My name is Alison McGeer, and I'm an infectious disease physician and epidemiologist in Toronto. Before I start, let me declare my conflicts of interest. My research in infection prevention and antimicrobial resistance involves a fair amount of work on vaccines, and I have both research funding and personal honoraria from many of the companies that market vaccines in Canada. I'm here today to ask you for help specifically with 2 areas in antimicrobial resistance. The first is the issue of what our current AMR trajectory is. As people pointed out yesterday, we've been relatively spared from the burden of AMR in Canada, in part because of the hard work of a lot of people across the One Health continuum in Canada. Nonetheless, it's really clear, as Victor has just pointed out to you, that this work is not enough. We have not great coordinated, but good surveillance systems across the country. Every pathogen, AMR resistance is increasing. We are losing ground, and AMR is accelerating. And it's now harming patients. So pre-COVID pandemic, our biggest problem in Canada tended to be that you had to think a little more carefully about getting a broader spectrum antibiotic to make sure a patient with risk factors for resistance was covered. All of us in infectious diseases now have seen patients who have become septic because they got the wrong initial antibiotics, not because people were incompetent, but because there were just too many conflicting choices and you couldn't do the antibiotic choice right. And my best analogy for what's going on with AMR is what's happening with climate change. As I've been watching the wildfires and heat events for the last 2 years, it's clear to me that despite a lot of work on trying to mitigate climate change, it's been too little too late. And AMR is obviously a different order of magnitude, but it is exactly parallel. A decade from now, I don't want your families and mine to be watching antimicrobials fail in hospital and be thinking the same thing, that we left it too little too late. We've got a narrow window where we can take substantial additional action on AMR that will fix things. We have evidence for lots of things that we're not doing, and we need to move on it now. So your first question, of course, is, okay, what are we not doing? And Victor's just pointed out to us. So think about the COVID pandemic for a moment. We didn't get out of the COVID pandemic because we had treatment. We got out of the COVID pandemic because we had vaccines and public health interventions. And getting out of the AMR pandemic, and it is a pandemic, even if it's not the same as COVID, getting out of the AMR pandemic has to involve prevention. It's not to say that antibiotic access, that development of new antimicrobials, that antimicrobial stewardship are not critical interventions. They are, and we need them, and we need more of them. But in and of themselves, they're never going to be enough. We need to broaden our efforts to prevention of infection, and we need to be looking at our federal action plan now and saying, where are the gaps in prevention, and what can we do to move forward on them? There's two particularly important areas in human health that I want to touch on. I want to do it because, honestly, the veterinarians and agriculture and environmental health people are ahead of us. Okay, they've been doing better than we have been doing in human health and AMR. So the first thing I want to talk about is vaccines. We need a national vaccine strategy against AMR in the same way that we have one against pandemic pathogens. One that covers vaccine development, manufacturing within Canada, but also one that ensures that we deliver publicly funded vaccines to Canadians. We, at the moment, our vaccine delivery system across the country is badly broken. It needs to be fixed, and it needs to be fixed now. And if you want to ask me a question about what the WHO thinks the benefit will be from fixing that, I'd be happy to tell you. The second thing I want to point out is that we also have a really significant problem with the transmission of antimicrobial resistant organisms within our healthcare facilities. Now, people will have told you, and they were right, that we use more antimicrobials in animals than humans, and more antimicrobials in humans in the community than in humans in hospitals. But we use our most powerful antibiotics in hospitals. We use them for our most vulnerable patients. And so hospitals are a crucible for antimicrobial resistance. And not all, but many of the pathogens that we're in increasing trouble with are pathogens where the antimicrobial resistance is arising and growing in hospitals. We have evidence both from Canadian studies and from outside studies that we don't have to tolerate that, but we have not put that evidence into practice. And so we urgently need a national conversation, and I think it has to come nationally, despite the fact that much of what we do in hospitals is provincial, to talk about why we haven't implemented those programs, whether we need to be implementing them or something different, and what
If you can please wind up, you will get some opportunity to talk about
what's going on with this.
the round of questioning.
Thank you.
Thank you. Thank you, Dr. McGurr. Now we will proceed to Dr. Simon Otto. He's joining us by video conference, so please go ahead. You will have 5 minutes for your opening remarks.
Good afternoon. Thank you, Madam Chair and the committee, for the opportunity to testify today. I'm Dr. Simon Otto. I'm a practicing veterinarian and an epidemiologist and a faculty member at the University of Alberta. My research focuses on One Health and the aspect of how AMR is a One Health concern, how it moves between and impacts the health of humans, animals, and their environments. I will speak to you about 3 key points that echo my colleagues. First, tackling AMR requires a holistic One Health approach that includes prevention of infections and stewardship of drug use. Next, we cannot manage what we do not measure. And last, resources are urgently required to tackle this silent pandemic. I want to reinforce that while drug discovery and development is important, it will not solve the AMR problem, as Dr. McGurr has said. AMR is a natural phenomenon of microbes that is exacerbated by antimicrobial use. Mitigating AMR requires an approach that prevents infections and emphasizes antimicrobial stewardship. Preventing infections will reduce the need to use antimicrobial drugs. We will never prevent them all, but we can reduce the transmission of infectious diseases in humans, food animals, and companion animals through management strategies. Vaccinations, as we've heard, are one important strategy. They reduce the severity and transmission of disease, thereby reducing the number of infections and the need to treat them with antimicrobials. Prevention goes beyond vaccinations. We rely heavily on water treatment, sanitation, hygiene, and food safety to prevent human infections. Likewise, we rely on management strategies to prevent infections in intensively raised food animals, the companion animals that are part of our families, backyard farm animals, wildlife, and zoo and other animals. Infections are inevitable, however. As veterinarians, we have an ethical obligation to treat infections in all animals under our care, and this is where antimicrobial stewardship is pivotal, using these drugs in a way to minimize the selection for AMR. Antimicrobial stewardship should be viewed as a continuous improvement strategy. AMR is inevitable, therefore there is no specific threshold of stewardship above which we can say we have done enough. Stewardship should focus on reducing unnecessary and improper use, such as areas where we revert to drug use in the place of making management changes that could reduce infections. This is where measurement comes in. Canada has a world-renowned AMR and antimicrobial use surveillance system that we've already heard about. However, the federal programs still have large gaps and important limitations. The Canadian Integrated Program for AMR Surveillance relies on a relatively small number of farms in the food animal commodities that are included in the program, which is incomplete. There's almost no animal pathogen surveillance, and there's no AMR surveillance in companion animals. The human surveillance system that we've heard about cover hospital infections, but beyond new pilot projects still suffer from large gaps in community medicine, long-term care facilities, and remote northern and Indigenous communities. While food animal production uses quantities of antimicrobials that exceed that of human medicine, we still do not have a clear picture of the true impact of animal antimicrobial use on AMR in animal or human health. It's clear that most resistance in humans comes from human use, just like most resistance in animals comes from animal use, with some limited examples of movement between them, which are important. Put plainly, we cannot manage what we do not measure. To truly support stewardship decisions by human healthcare practitioners, veterinarians, food animal producers, we must have a more comprehensive surveillance program that builds on the strong foundation we currently have. The environment, such as water, soil, and crops, is also an important area for surveillance that's lacking. It's a large but poorly understood reservoir of AMR that receives effluent of resistant microbes and drug residues from human and animal settings. All this points to the need for a substantial resource investment in money, expertise, and infrastructure. While drug development is an important piece, so too are the investments in research to identify management strategies for animal and human health, vaccines, diagnostic testing, and social science to understand how to effectively implement these strategies in a reluctant human population. All these strategies must keep animal, human, and environmental health in mind in a One Health context. The needs of each sector will be unique, but will impact one another. We must have a comprehensive One Health strategy for Canada and the globe. The time is now, as this silent pandemic pushes us towards the post-antibiotic era. Thank you to the committee for making AMR one of your priorities and for the opportunity to discuss this today.
Thank you, and thanks to all the three witnesses for their testimonies. Now we will start with our first round of questioning, and we will start with MPD Ryder for 6 minutes. Please go ahead. You have 6 minutes.
Thank you, Chair. I just want to thank all the panelists for being here today and joining us in this discussion. Victor, I'm going to direct my questions to you. You're from Vancouver, where I know this drug crisis we're facing is reached an all-time high and, quite frankly, out of control. I know in each of our ridings as well that we've been touched by this drug crisis happening here in Canada. On October 7th, the BC Premier admitted that the decriminalization of drugs was a mistake. And I just want to know from you, how has the increase of our opioid pandemic increased infectious transmission in the hospital that you come from?
So I see opioid use and antimicrobial resistance as syndemics. These two conditions, when they interact along with other factors, amplify and make both of these conditions worse. the way we have to address both opioid use and AMR from a syndemic approach is based on the approach that we've taken here in British Columbia with expanding the treatment as prevention strategy that was used and adopted by the UNAIDS and Canada to target HIV elimination. Using that approach of treatment as prevention and the strategies surrounding that, we can address these conditions as a whole as opposed to individual fragmented conditions. Because if we try to address each one of these individually, the scope and the costs are much more significant. But having a packaged approach such as treatment as prevention strategies will help address them in a way that's sustainable for the healthcare system.
Thank you for that. You mentioned too that we don't have thoughtful programs in place and no surveillance to measure the impact of the antimicrobial resistance. And so in that, I'm curious as to how are your doctors and nurses being affected by this? And is there any data, is anybody tracking this? Is there any data to keep an eye out of the exposure to infection and then therefore resistance, even just boots on the ground with you as doctors and nurses in the hospital?
So to clarify, I mentioned that our access systems need to be improved and our surveillance systems have room for improvement in terms of timeliness and also ensuring that there's no redundancy in the surveillance systems that we have. At the hospital level, where my colleagues in nursing and physicians and other healthcare providers, the way the antimicrobial resistance affects us is, first of all, how we have to practice, what things change, things we need to change in a daily practice to minimize the chance of transmitting infections to our patients, and then also having patient-to-patient transmissions within the healthcare facility. Because of the nature of how healthcare is delivered in acute care facilities, infections that are antimicrobial resistant or even hospital-acquired infections are at some level invisible because one provider working with an individual doesn't have that whole continuum of interaction to see their healthcare journey. So if a person acquires an infection 7 days into their hospitalization, that is an antimicrobial resistant infection, the healthcare providers interacting them with at the time may no longer be following them throughout their hospital journey. And when a new team or a new provider comes on, often it's just recorded in the chart as an infection, but it's not obvious to the healthcare providers that this is a hospital-acquired infection. And that's why we have hospital infection prevention and control teams as one group that helps with surveillance. And what I'm suggesting is that the surveillance data that's acquired and ascertained by the team needs to be actioned upon, and there needs to be accountability within the system, not only at the local level, but also have that captured at a provincial and federal level so that we can increase the awareness of the impact of these hospital-acquired infections on individuals and not continue to deal with it the way we are now, which is from the healthcare provider's perspective, unless they are dealing with someone who is acutely dying in front of them, that sense of urgency and problems with antimicrobial resistance are often invisible.
There was a report that came out that said 1,250,000 Canadians left an emergency room without being treated in 2024, an alarming increase of 35.54% over a 5-year period. How many diseases do you think are slipping through the cracks when this amount of people aren't even being treated in Canada?
When individuals seeking care aren't getting access to care, I think all the different reasons they've sought care for could be missed. And I don't know what proportion of that would be related to infections. We don't have a system to capture that.
Thank you very much for your time, Victor.
Thank you.
Thank you. Now we will go to MP McKelvey for 6 minutes. MP McKelvey, please go ahead.
Thank you, Madam Chair. My first question is for Dr. McGeer. So you've done a lot of work on E. coli, antimicrobial resistant E. coli. And I'm just wondering, I know some of your work has focused on monitoring wastewater, and I'm just wondering, what is the state of science around monitoring wastewater, and is there somebody that's doing it well that we could model any such programs around?
So the challenge with monitoring wastewater for antimicrobial resistance is that antimicrobial resistance concentrates in wastewater, honestly, for reasons that I don't think we understand. So we looked at wastewater in Toronto, for instance, in 2014, when we had, right at the beginning of seeing patients with resistant organisms that we call carbapenemase-producing organisms. Okay, it doesn't matter what they are, okay, they're just bad. And they're called CPE, and we were seeing very few patients in hospitals, but we were already seeing consistent detectable concentrations in our wastewater treatment plants. And that's been seen everywhere around the world. That's a function of this real concentration in wastewater treatment plants. Now, you could see geographic differences between where patients are coming from. So in Toronto, right, a very large South Asian population, and much of South Asia is endemic for a particular type of CPE. So you could see some differences. And I think, so I think actually looking for broadly resistant gram-negative E. coli organisms in wastewater, we actually don't know how to do. We don't know how to interpret it or how to do it well. Our last study, when we looked at organisms, we could see the same genes, but very different organisms carrying them, as if the genes are being come from humans through the hospital wastewater system primarily into our general wastewater system. And then in our general wastewater system, the genes actually get transferred to other organisms whose home is wastewater systems. So I think that's difficult. The second thing about wastewater, unrelated to surveillance, is that, well, of course, wastewater treatment plants are to reduce bacterial concentrations, right? But they don't preferentially reduce antimicrobial resistance. So if antimicrobial resistant organisms from hospitals are going into your wastewater treatment plants, antimicrobial resistant organisms will leave the wastewater treatment plants in a much diluted form, but they'll still leave. And one of the interesting things about looking at wastewater treatment plants that people are still working on is that there are some wastewater treatment plants where you do seem to get some preferential reduction in antimicrobial resistance, and there are others that look pretty similar to, admittedly, the uninitiated, okay, where you do get substantial reductions. So I think that in addition to working on our surveillance systems for wastewater, which we need, we also need to be looking at whether in wastewater treatment plants we can have technology that will preferentially reduce antimicrobial resistance so we're not contaminating the environment from what's happening in our hospitals.
So is it possible, and has anybody done it at the point of source? So instead of sampling at water treatment plants, sampling at effluent from hospitals, long-term care, and has there been thoughts towards shifting towards monitoring being more, I guess, kind of at the source or at the discharge points as opposed to once it's combined in a pipe on the way out? And is anybody doing that internationally? Is there anything we can learn from that?
There are a bunch of people doing it internationally. It's not inexpensive to do, and Victor and Simon weigh in if you know because that tracking from hospital to through other pathways into wastewater treatment plants, it's also relatively complicated, right? In Toronto, our water doesn't always go where you think it goes in the system, as I'm sure you know, and so figuring out how to do that tracing is actually difficult. I'm not aware that there are people who are doing it really well at the moment.
So maybe, Dr. Otto, do you have any recommendations? What could we be doing better in this regard in terms of tracing bacteria in effluents?
I think the biggest challenge is we don't have any official monitoring set up in those spaces. And I think most of the things you see internationally are people are doing it as part of funded research projects. So we're doing research on how to do it, but we don't actually have programs set up that are doing it uniformly. You know, that long-term care is a great example where we have huge gaps in surveillance where we really don't know what's going on in terms of AMR surveillance there. So I think it's an opportunity, but would require substantial investment.
If we're going down that road, the questions I asked previous panelists, so was more on, in your case, you're all the experts in the actual pathogens themselves, but some of them were also experts in the antimicrobial and in the pharmaceuticals. So would that also have to be an important part of the approach? Should we be looking at combined, if we're going to start looking at monitoring or testing and piloting monitoring, should we be monitoring both the genes but also the antimicrobials and what is coming out through and back out into the environment in that regard?
I think from a residue standpoint, yes, but the other part of it is tracking, with detail what drugs are being used, for example, in a long-term care facility to know what's coming out. If we can't link antimicrobial resistance data and pathogens and bacteria to the use at, whether it's residues or use in those populations, and it's hard to understand what's driving resistance levels.
Typical pathogens, they love us because we're warm and we have, okay, I'll ask later.
Okay, thank you. We will now proceed to MP Blanchet-Jonca. Please go ahead, you will have 6 minutes.
Merci. Je salue les témoins qui sont avec nous aujourd'hui.
Thank you very much to all the witnesses. So 22% of antimicrobials were for veterinarian use. Out of the rest, your program gets a return on the investment. How to conciliate this objective with the urgency of preserving the use of antimicrobials and to fight against? Do you have an estimate of this economy? Could the witness repeat to who the question was addressed? I did not hear it. Pourriez-vous
Can you please repeat it?
Dr. Long.
Yeah,
The question was for Dr. Lung.
Okay, I missed the first part of the question. If you could repeat the question one more time, please.
If you can please start from the beginning. Thank you.
Donc, Dr. Long, en 2020, 82.
So, Dr. Lung, in 2020, a great percentage of the medication was for veterinarian use. The rest was for human. Your program has a return on the investment financially. How can you get this economic objective with the urgency of keeping the usefulness of antimicrobials and fight against bacteria? Do you have an estimate of what kind of economies are you talking about?
So in the hospital antimicrobial stewardship programs, most return on investment is a combination of how much antimicrobial costs are saved through the programs that are implemented, as well as the projected costs in prevention of driving resistance, increasing adverse event rates associated with these antibiotics, as well as all the other downstream impacts that happen when there's overuse of antimicrobials. So at a human scale level, antimicrobial stewardship programs in the hospital is, when compared to animal scale in terms of quantity, grams of antimicrobials, is significantly less. But the return on investment economically is measured in ways that focus on how we reduce antimicrobial overuse in the healthcare system, in hospital systems, and also how that will result in reduction of adverse events related to antimicrobials. Because adverse events, when we think of antibiotics, are not just antimicrobial resistance. They're all the things that drive medication consequences. And we know that antibiotics as a class, when compared to other classes of medications, is often the number 2 or 3 driver of of adverse medication adverse events. So the measure of return on investment has to be broader in scale and not just focused on cost of procurement or cost of use of the antibiotics itself.
Je poursuis vers vous. Vous travaillez avec des équipes multi...
You work with multidisciplinary team and you set up surveillance for these organisms. It is a complex problem that deals with environment, humans, and animals. But research is very often in a silo, which means that you really need interdisciplinary projects. Do you think a better support of research would allow us to face this threat to antimicrobial resistance?
Research is definitely an important pillar in confronting antimicrobial resistance, but research alone is not enough. And so, yes, the research has to be applicable, translational, or at a basic science level, have all of the different types of research have impact on dealing with antimicrobial resistance, but research alone is not sufficient.
Merci. Dans le budget fédéral de 2024, nous annonçons la création d'un organisme cadre qui n'a toujours pas vu le jour jusqu'à maintenant, qui visait à mieux coordonner les 3 conseils subventionnaires et à encourager la recherche interdisciplinaire. Selon vous, faut-il renforcer...
According to you, should we reinforce this approach?
And I missed the first part of what approach we need to reinforce.
Can you please repeat the question?
La présidente, je crois qu'on voit les défis techniques, l'importance d'avoir des...
We can see how hard it is. It might be easy if we had the interpreters right here in the room. I hope that you hear me. So I'm sorry, I'm going to have to repeat. So in 2024, we had announced the creation of an organization that has up until now not happened to encourage interdisciplinary research. Do you think that we should reinforce this multidisciplinary research?
I don't know which specific organization you're referring to that was established to look at this. I would have to reference specifically which specific organization you're referring to answer that question of whether or not I think it's beneficial to ensure that this funding gets increased or this program continues. I'm not sure.
Merci. Madame la Présidente, combien de temps restant avec tous ces problèmes?
How much time do I have actually because of all these technical problems that we've had? I do apologize.
So it's 2 minutes and 38 seconds.
Merci beaucoup. Donc, Dr. Lang, je poursuis vers vous.
Dr. Lang, so Quebec and the provinces are getting more and more pressure because of AMR. Do you think that this problems with the financing is not helping to keep us with the correct teams and a correct way of dealing with AMR?
I don't know the specifics of how much is allocated in Quebec and what it's allocated to, but I would say that whenever funding is allocated, the important things that I think would be useful is the accountability for how that funding was used in order to learn if the funding was appropriately allocated and therefore requires more extensive funding, or whether we can learn from how the funding was allocated so that prior to just increasing finances towards a problem, we better understand how it can be efficiently used for fiscal sustainability.
Dr. Lang, je vais poursuivre pour Dr. McGeer. Le Dr. Herman Barkema, professeur.
Dr. Herman Barkema from the University of Calgary recently said that Quebec is now ahead because they forbid some antimicrobial in agriculture, and it's working really well. Do you think that this type of initiative, which is based on evidence, should be valued in a coordinated approach, but still taking into account regional specificities?
It's both an advantage and disadvantage in Canada that we have differences between provinces, because sometimes you can see that Quebec, and in many ways in prevention, Quebec is ahead of many of the rest of us in provinces with a greater value put on prevention and protecting people in health. And so I think there are a number of places across Canada where you can choose, pilot projects or different policies that are working really well in one province and that we could transport to other provinces. That is clearly one of them within the agricultural sector. As you know, sometimes it's more difficult to move things from one province to another.
12 seconds. Okay, thank you. We will now start with our second round of questioning with MP Mahal. MP Mahal, you will have 5 minutes for your round of questioning. Please go ahead.
Thank you, Madam Chair. Dr. Leong, I would want to come to you for my questions. As you have said and in your initial statement that there are barriers in the Canadian market. Accessibility is falling behind. We are at the bottom of G7 when it comes to the accessibility and all those challenges. And given that the last 10 years of liberal overspending and now they are planning to cut on the budget, how do you think that is going to, there are expected that the budget is going to cut heavily on all these important issues. How do you think it's going to impact on the AMR and research related to AMR?
I think overall with budget cuts, the first thing that may likely happen is a decrease in progress towards advancing what was previously committed to. However, I think that with budget cuts also comes an opportunity to relook at how the programs have developed and whether or not there's opportunities to do things within the fiscal constraints, such as creating new processes, which often are not as expensive as creating access to drugs. Because I think that at the end of the day, current drug access often is limited by inefficient and outdated processes and not necessarily all tied to financial costs of procurement for some of these drugs. So I think that with fiscal constraints, it'll force us to really consider more efficient processes and innovative processes that have been tried by other G7 countries that may not result necessarily in increased upfront costs. Or at least at the end of the day, even if the upfront costs are higher, the return on investment, if the process is established to be efficient, usable, and really practical at the end users, we can still, for now, be able to work within solutions that are allocated to the various groups to make these drugs accessible.
During your testimony, to answer my colleague's question, I think I did not at least understand it clearly. You said that she put a question to you that what is the risk of doctors and nurses being at the risk of getting those AMRs and getting those transmitted to them while they are on duty? And how do you think the federal government is doing, the bodies those are concerned doing in regards to protection of those doctors and those nurses working on the front line?
So healthcare workers, when dealing with patients with antimicrobial resistant infections, are going to be at risk as either transiently colonized, meaning that it becomes part of some aspect of their body, for example, the skin, but they may not be infected with it. They can then also act as the potential for transmitting to other individuals. And so that is why it's fundamental to have infection prevention and control measures within facilities, as well as proper occupational health approaches. And when it comes to occupational health approaches, we saw, for example, with the COVID pandemic, some of the challenges, thinking about what is our best allocation of resources to focus on the prevention of acquiring or transmitting an infection. And it doesn't have to come down to only personal protective equipment. I think an aspect in hospitals that we should be more focused on as we modernize infrastructure is engineered infection prevention and control measures. Doesn't rely necessarily on the individual healthcare worker to be aware of some of the ways infections transmitted. For example, infections that are transmitted through the air, infections that are transmitted through surfaces. There are increasing number of useful and cost-effective engineered infection prevention and control measures that can be incorporated in new hospital builds, but also retroactively sort of retrofitted into some older facilities.
You mentioned that.
Mr. Mahal?
Can I have that in writing? I just have one question.
If something comes up like maybe another round or something, we will see. Otherwise, then in the end, we can deal with it. Now we will proceed to MP Noor Mohammed for 5 minutes. Please go ahead.
Thank you, Madam Chair, and thank you to our witnesses for being here. I'd like to start with, I guess, a question for all three of you. I'll start with Dr. Otto, then Dr. McGeer, and then go to Dr. Liang. We have seen over the course of the last little while, and Dr. Otto, you spoke about the importance of vaccinations, of vaccines, of vaccine development. We have seen an alarming rate of sort of vaccine hesitancy, sort of criticism of the use of vaccines, including by politicians, which, I would argue causes a substantial amount of public concern and leads to distrust of science. In a time when you were talking about sort of antibiotic resistance and the need now to develop new vaccines urgently, quickly, and to get those vaccines to people, particularly who are on the front lines of some of these emerging illnesses and diseases, what would you say to the politicians and to those that are spreading sort of some of this misinformation about vaccines?
I think it's twofold. We need to focus on the messaging that vaccines do work. They're not going to prevent infection from happening. They're going to reduce disease, reduce transmission at the population level, and reinforcing messaging about vaccine safety. And this isn't just in human medicine. Vaccines are incredibly important on veterinary medicine, animal health side as well. And I think I want to reiterate my point about research around the social science piece, because it's not just the political side. The human population is now quite reluctant because of messaging around vaccines and misinformation. So I think we need to fill that void with the scientific evidence, but we need to do it in a way that's digestible for people, as opposed to reverting to the stats and the technical pieces. The research piece around siloing and One Health as well. I mean, our research agencies federally are set up to fund human medical research, science, and STEM and animal health and social science. And it creates a split, making some of that One Health research across those spaces difficult to tackle some of these problems.
Dr. McGeer, same question.
So I think there's three things. The first is that, yes, there's been a substantial impact, but we're still doing pretty well with vaccines. The Ontario vaccine program for RSV and long-term care, which you would have thought in the middle of COVID and flu and general catastrophe would have been really difficult and was started way too late. We've vaccinated 70% of residents of long-term care facilities, okay? And that's actually an amazing testament to people who work in long-term care and the families of people in long-term care that we can do that. So yes, we need to be worried about vaccines, but we don't need to be panicking about the state of vaccines. The second thing about vaccines is that partly because they're prevention, and you know how hard it is to value prevention, right? I've spent my life in infection prevention, and you know what a really good day in infection prevention is? It's a day when nothing happens. And pitching that to my CEO is really hard. So vaccines are hard because they're part of prevention. They're also hard because of the neuroscience of thinking about taking risks for future benefit. Okay, so a piece of this is that we will never get away from vaccine hesitancy and vaccine misinformation. It's been with us since the 1700s when Jenner first started. It will be with us 400 years from now. Okay, unless we get past vaccines in some fundamental way. So a piece of it is we just need to keep working at it. But you're absolutely right that what we need now, particularly with what's going on south of us, is a real focus on what we can do to protect people from disinformation, and particularly what we can do to protect younger people from disinformation who aren't as, don't have the faith in vaccines that us older folk have, and also, consume much more of the social media where disinformation is spreading. It's a very significant issue that we need to focus on.
Thank you. I turn it over to you, Dr. Liang.
And I would say that specifically for the vaccines, even though sometimes we think that it may be vaccine hesitancy, the more common problem I encounter for people who are under-immunized for things that they are eligible for is awareness and access. There are lots of barriers to vaccine access across the country based on how it's currently funded. And a lot of the times, specifically, for example, the program that we've started at our hospital for vaccination against zoster or reactivation of chickenpox. This program is funded by the First Nations Health Benefits Program, but the logistics around getting it is the barrier, not the people who are willing to get the vaccine.
We'll proceed to MP Blanchet-Jonker for 2.5 minutes. Please go ahead.
Oui, prochaine question pour le docteur Otto.
Next question for Dr. Otto. There is a report from the Horizon Center said that AMR is one of the first cause of worldwide mortality. So you're working from farm to fork. Do you think that our government is weakening our capacity to answer this particular challenge?
I think my comments are not specific to government. I think our challenges of understanding farm-to-fork transmission are hampered by the gaps in our surveillance program, which are not specific to this government. Those programs have been well designed by thoughtful people, but budgets that predated the current government and past governments have continually created challenges for them to expand those programs. And as I mentioned, I think there's gaps in understanding there. And while we have a world-renowned system in terms of its design, the big gaps are in terms of coverage, animal health, animal pathogens, and the areas that I mentioned in my testimony earlier.
Et qu'est-ce que vous souhaiterez concrètement dans le prochain budget?
What would you like in the next budget in a real term to face this world issue of the antimicrobial resistance?
I think what we've seen with surveillance budgets over the last 10 to 15 years is they've continually been decreased to the point that their programs are being run by a relatively small number of experts in the space without a lot of supporting cast there. So there needs to be investment in the personnel to support the programs, but also to expand their coverage. If you look at animal pathogens, for example, on the AMR side, the majority of animal pathogen surveillance is currently funded by research funding as opposed to ongoing budget funding. So that's a specific area that would help. And I think, as I mentioned, and Dr. McGeer can speak more to this, and Dr. Liang about the infectious, AMR surveillance, long-term care, and the community side to have a better understanding on the human medical piece. Those are currently funded as pilot projects, but need to be expanded to more mainstream surveillance programs. And then addressing how we work with provincial data to get some more integration with the provincial data sources that exist that Dr. Liang spoke to.
Time is up for MP Blanchet-Jonker. We will have 1.5 minutes each for the Conservatives and the Liberals, and then the panel will come to an end. So Mr. Baldinelli is on the list. I don't know if Mr. Mahal wants to ask his question.
I'll take this opportunity, and I just want to thank the witnesses for being with us today. Dr. McGreer, in your opening comments, you said you're going to discuss what it is we are not doing right. And one of those things that you talked about was transmissions within hospitals. And I think you said, it was kind of shocking, that it's the crucible for AMR. And so do poor healthcare practices like overcrowding in our hospitals, hallway healthcare, increase the risk and acceleration of AMR in Canada?
The answer to that is yes, but it's more fundamental than that. Just even our best, newest hospitals with what people are doing as current best practice have not effectively reduced transmission of AROs in the hospital. So it's organizing yourself to do that is difficult. It requires an investment of funds on the part of the hospital, which is hard for hospitals to do. And of course, crowding and shortages of staff and less space unquestionably makes it worse. But it's not, we have a core problem that is beyond that.
Dr. Liang, you had said in your opening remarks, you stated that Canada is falling behind in terms of the antimicrobials that are available. In fact, I mean, our excellent note that was prepared by our staff from 2010 really to 2021, and Dr. Salama mentioned it the other day, that only 3 out of 18 new antibiotics launched worldwide are available in Canada. And you talked about some of the program, the approval processes. And
time is up, Mr.
And if you could just, in comments, maybe written comments, provide some of your concerns with the Health Canada Special Access Program and how that can be improved.
We will now proceed to MP McKelvey for 1.5 minutes before we end this panel. So MP McKelvey.
Thank you, Madam Chair. So it's clear we need all hands on deck. We need municipalities who ultimately treat wastewater, monitor wastewater. We need provinces who generally work in agriculture and that sort of thing. We need the federal government. We do drug approvals. We fund research. Dr. McGreer, you mentioned WHO and that there was some thoughts around how we're working with them that you could share with us. So how important is international collaboration that we continue to do that despite this pressure that we see where people are wanting us to walk away from that?
So I think there's two pieces to that. One is fundamentally international collaboration, and there is no question, many people have talked about it in the last 2 days of hearings about the fact that microbes don't know what borders are, right? And so all of this has to be global, and we will unquestionably be better off if we're doing it globally. The prevention of infections in any other country effectively prevents their importation into Canada, and the prevention of infections in Canada prevents their export to other countries as well. So there is no question that everything we do in science and research is better if it's a global collaboration. But it's also, I think, important, and I hear myself as I'm saying this, okay, so I want more money for AMR in Canada, and I also want us to be spending more money on supporting other countries that are poorer and less privileged than we are, because the United States funding is gone. And as a consequence of that United States funding being gone, hundreds of thousands of children will die earlier deaths around the world. So this is a time when we need to think really carefully about how we see our global responsibilities as Canadians and how much more money we can put into funding programs that will save lives from AMR, but just from infections in general in other countries. This is really, I think, a time when the rest of us need to try to step up and replace as much as we can what has been lost in the U.S. programs being shut down.
Thank you, Dr. McGreer. Time is up, and I really want to thank all the 3 witnesses for your important testimonies towards this study. And with that, the panel comes to an end, and I will suspend the meeting for a few minutes so that the other witnesses can take their space. Thank you. I would like to make few comments for the benefit of our new witnesses. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. We are joined by two witnesses for this panel. I would like to welcome our witnesses, Jenna Soué, antimicrobial stewardship pharmacotherapy specialist, and she is joining us by video conference.
Madame la Présidente.
SRSR. Yes, please.
Oui. Vous m'entendez bien?
Can you hear me properly? Can you hear me?
La traduction.
There seems to be a confusion. We can hear two voices at the same time. I don't. Hello?
See if there is a reminder that all comments should be addressed through the chair. Sorry for that. We would start with our witnesses. First, we will proceed to Jenna Soué for 5 minutes. You can please go ahead. You will have 5 minutes for your opening remarks.
Good afternoon, Madam Chair and members of the committee. My name is Jenna Soué, and I'm a clinical pharmacist specializing in antimicrobial stewardship. I practice in a large academic hospital in Toronto, where my work centers on optimizing antimicrobial prescribing for hospitalized patients. I've also led research on antimicrobial resistance and stewardship education in Canadian pharmacy programs and developed a curriculum framework to enhance teaching of this content. I thank you very much for the opportunity to appear before you today. Antimicrobials are critical tools in modern medicine, required by most Canadians at least once in their lifetime. However, rising rates of antimicrobial resistance, or AMR, threaten their effectiveness and, in turn, the health of Canadians. The World Health Organization has declared AMR as a silent pandemic and one of the top 10 global public health threats. Projections from the Council of Canadian Academies suggest that by 2050, nearly 14,000 deaths annually in Canada will be directly attributable to AMR, which translates to the loss of approximately 38 Canadian lives every day. The clinical and economic impact of AMR is felt across Canada's healthcare system. 1 in 4 infections are now resistant to first-line antibiotics. For patients, this can mean delays in receiving effective treatment, exposure to more toxic second and third-line therapies, and increased risk of complications or harm. For the health system, this comes with a financial burden, resulting from longer hospital stays, management of drug-related side effects, and use of more costly antibiotics of last resort. While resistance occurs naturally, it's accelerated by the misuse and overuse of antimicrobials across the different sectors. Antimicrobial stewardship, which is coordinated efforts to promote and evaluate judicious antimicrobial use, is a key strategy in preserving the effectiveness of these drugs. While many hospitals have established antimicrobial stewardship programs, there remains a significant gap in community-based initiatives, despite the fact that the majority of antibiotics are prescribed in these settings. An estimated 15 to 25% of antibiotic prescriptions in Canada are considered unnecessary. Addressing this issue requires investment in improved methods of diagnosing infection and funding for stewardship initiatives that incorporate behavior change strategies to reduce inappropriate prescribing. Successful stewardship initiatives also require a well-trained and empowered workforce to implement them. Highlighting the need for coordinated educational curricula for health professionals and identification of AMR as a priority by accreditation and licensing bodies. The issue of AMR in Canada is further compounded by limited access to critical antibiotics. The Auditor General's 2022 report highlighted that Canadians lacked market access to 19 of the 29 antibiotics classified by the World Health Organization as antibiotics of last resort. Furthermore, of the 13 what would be considered novel antibiotics that had become available since 2010, only 2 were available in the Canadian market, a number that was staggeringly low compared to other high-income countries. This lack of access results in extensive resource utilization to import these drugs from other countries and causes delays in initiating life-saving care for patients. Better incentives are required to encourage pharmaceutical companies to bring these critical antibiotics to market in Canada. In summary, AMR is not a distant or abstract threat. It's an issue that affects all Canadians. Without the ability to reliably prevent and treat infections, life-saving treatments like major surgery, organ transplant, and cancer chemotherapy become far more dangerous, if not impossible. While there is progress being made through the Public Health Agency of Canada's Pan-Canadian Action Plan, there is still more work to be done to deliver the comprehensive and coordinated response that's needed. Funding of stewardship initiatives, particularly in community settings, along with enhanced training of health professionals in this field, will help to promote appropriate use of our currently limited arsenal of antibiotics. In addition, Canada must not just invest in the development of new antimicrobials, diagnostic tests, and preventative strategies, but also act now to ensure that Canadians have timely access to these new drugs and technologies once they become available. Thank you.
Thank you. And our second witness for this panel is Dr. Scott Weiss, Professor, University of Guelph, and Director, Center for Public Health and Zoonosis. So, Dr. Weiss, you will have 5 minutes for your opening remarks. Please go ahead.
Thank you, Madam Chair. Thanks for the invitation. So I deal with AMR in animals and at the human-animal interface, ranging from the individual animal to the population and locally and globally. And that's how I'm presenting some of my thoughts and comments. And really my theme is it's a complex problem. I want to emphasize the complexity of the problem, the oversimplification of the problem, the lack of action-based approaches, and the need to consider animal and human health as integrated but as separate issues. You've heard about One Health, probably repeatedly. It's a One Health problem. It's good we're talking about One Health, but we have to remember that One Health isn't human health and everything else. One Health is human health, animal health, environmental health under a One Health umbrella. Some things are definitely One Health. Many things with AMR are strictly animal health or strictly human health. And sometimes we focus too much on One Health, not knowing what to do, and it's a barrier to action. So we need to think about where we can get synergies with the One Health approach, but not fixate on the One Health approach. As I think Simon said, we don't know the contribution of antibiotic use in animals to antibiotic resistance in humans. It's probably a very small proportion, but if it's a very small proportion of a very big problem, it's still something we need to address. So we have to do it. But at the same time, we have to remember there's an animal health component, and we have to think about the animal health, the animal welfare, the economics of food production, and the food security issues that come along with this. The World Organization for Animal Health has estimated that by 2050, if AMR is unchecked, food animal production losses will be equivalent to the food needs of 750 million to 2 billion people. That's a staggering number. A very small percentage of the impact will be in Canada, but a small percentage of a staggering number is still something we need to pay attention to. So we have to think about the breadth of the issue and about action. And even that doesn't show the issues completely in animals. We have companion animals. We have untold impacts on them. We are losing animals from resistant infections. Just before this session, I spent time doing 2 emails about 2 animals with life-threatening multi-drug resistant infections, 2 pet animals. And that impacts the animal's health and welfare and the emotional impact on their owners, their family members. So we need to address AMR in humans and animals. We have to realize that the issues are different. There are a lot of similarities, but there are some massive differences. A variety of innovation needs were stated in the standing order for this committee. Among them were drug development and surveillance. Obviously, incredibly important issues in human medicine. In veterinary medicine, not as much. I don't want new drugs for food animals. I want to make sure we can keep using the drugs that we have. I have a limited need for new drugs in companion animals, and I want to use them as little as possible. We have diagnostic testing needs. Yes, but all those are too late. We're addressing the end result. We can't address the AMR problem by addressing AMR. We have to address the impact of AMR, but we have to address why we have AMR And that's because we have antimicrobial use. And why do we have that? Because we have health problems or perceptions of health problems. So we need to address AMR itself, but we have to address the underlying causes. Otherwise, we're trying to keep up with a problem that's much more nimble than we are. And I think that nicely describes antimicrobial resistance. So for animal health, we need innovation. But that's not necessarily new drugs, new tech, new technology, new toys. It's innovation that targets, well, health, better animal management, better nutrition, better vaccines, better access to vaccines and alternatives, better ways to raise animals, better access to veterinary care, changing human behavior, which is very difficult to do, getting social science involved. We need things that will improve animal health and human health. These aren't often considered innovation, though, especially when you're trying to get funding or attention. You know, raising animals better, making their lives better, rearing them better, better access to care, doesn't come across as innovation very often. It's not tech, it's not toys, it's not sexy, but it's the foundation, and it's what we need to do. And Dr. Otto alluded to this too, or well, directly addressed this too, surveillance. We need better information. We need actionable information. Surveillance itself tells us what the problem is, but it has to direct us to a solution. And if we have very crude, very patchwork surveillance programs, we don't have the action step. And that's probably part of the issue right now. We have surveillance that's at a very high level in animals, but it doesn't direct what we do. Crude numbers are good for sound bites, but they're not good for action. We have multi-sector interest, motivation, foundation for better action-oriented surveillance, but we need sustained funding and, well, to be honest, political will to come along with that. We need to and we can markedly improve antibiotic use in animals. We know we need to do that. But we also have to recognize there's a role for them in care. Right? As a veterinarian, my obligation is to take care of animals. Part of that's using antimicrobials. A lot of that is making sure they don't need them. So we have to accept that we're going to use antimicrobials, but we don't have to accept the status quo, which is using them unnecessarily and not addressing health. So use as little as possible, but as much as needed, really, is the approach that we have to think about. And my final point, if I have another 30 seconds, it's complicated. Right? This is not something we can solve with a simple single solution or a single sector. It's everyone doing little things. So we need support for sustained and aspirational action. We can't do it with little piecework activities. And the other issue, this is something that has to be done spanning decades and generations. It doesn't span granting cycles for an agency. It doesn't span election cycles, single cycles. This is something we have to be gearing up for decades, and we don't do that very well. We don't aspirationally plan efforts that are going to impact for years upon years, even though that's what we need to do. Canada's had a very strong brand with AMR internationally, and that's been slipping. We still have very strong people. So we have the foundation here. We have some very good people. We have some very good structure. We have to get back to where we are with the action component. So I appreciate the efforts of this committee, and thank you for having me here.
Thank you, Dr. Weiss. Now we will proceed with our first round of questioning, and we will begin with MP Ho for 6 minutes. Please go ahead.
Thank you, Madam Chair. My question is directed at both witnesses. I guess we can start with Ms. Sove and then Dr. Weiss. So back in 2018, the House of Commons the government received a report on the status of AMR, and the issue was brought in a comprehensive way for the government to take action. So it doesn't appear that the government has taken, this Liberal government has taken much action since then. So are you disappointed in the lack of progress in the last 7 years? We can start with Ms. Sove.
Yes, thank you for the question. So I think there has been some progress and definitely some steps. Witnesses before me have cited also the Pan-Canadian Action Plan developed by the Public Health Agency of Canada. I do want to say there are a lot of great recommendations in that report and action plan, and it's difficult for me to assess without the most current information exactly where we are in implementing some of the steps there. I think if in the 5-year target they were to implement everything in that action plan, we would be in a much better place with respect to AMR than we have been in the past or are currently. So there is a one-year progress report on some steps that have been taken, and I think still waiting the report from year 2. So I would say progress has been made or is underway, but whether we are on track to meet some of those lofty objectives is difficult to say.
Years just have come up with a framework, and little has been done. Dr. Weiss, what do you think about that?
For more action. It's an action plan, and we need more of an action component. Yes, it's been sitting there for a while, and it was developed over a long process, so it's a bit of an outdated action plan, if anything, but it still provides an excellent framework. It needs to be funded. I think that's the biggest thing. There are a lot of things that could be done. There's a lot of interest in doing it. There's a lot of work that's being done, as I think Simon mentioned, off research grants and little pilot activities that could be harmonized together with a more structured approach so we get a better impact. And related to that was mentioned earlier, I think, or the other session, Drs. Jerry Wright and Andrew Morris were commissioned to put together a plan for a network, a Canadian network to enact this, and a few of us were involved in that. And that report, I think, really set out how we can act on this, but it hasn't received any action either. So there's a foundation there, but we need more will and funding and coordination.
It's concerning. I mean, it's great that you brought up the lack of funding, and this report's been collecting dust over the years, and the lack of action is quite disappointing. I mean, there's only about $1 billion, a little over $1 billion of health research funding, which is quite precious if you think of all the vanity projects the Liberal government has undertaken. Like, we spend well over $60 billion just to service the debt. So if you think about it, just $1 billion, a little over $1 billion for health research. And they used research funding for things like in the last weeks we discussed they spent $75,000 to study German children's books. That's research money that's going into it, not even so that's taken from the funding. So there was some. Just want to go back to some of what the committee member from last session on Monday talking about AMR. That apparently he alleges that there's a rhetoric about a skepticism, I suppose, I'm paraphrasing, about countries working together. And apparently there's this rhetoric that they don't want to be involved in cross-border research, and apparently, being ready for pandemics is a terrible thing. I'm quoting here, and apparently that is leading, according to him, that it's showing a lack of urgency and trust in science and trusting in medicine. But I took some time to think about those comments that were made in Monday, and then I realized in May 2019 under the Liberal government's watch, that the Global Public Health Intelligence Network, the GPHI, and essentially it's a Canadian federal government agency to sort of operate as a medical Amber Alert system, and its job was to gather intelligence and spot pandemics, and some of the witnesses here have described this as a silent pandemic. But in May 2019, the resources were completely redirected to other causes, and it has hindered our ability to be prepared for the pandemic. And you saw all the chaos that ensued from the federal government and the lack of preparedness and the lack of action. Does that concern you that funding is being cut? This government has announced funding cuts of 15% to public sector. They're redirecting resources for surveillance for pandemics. Dr. Weiss, why don't you start with that? Does that concern you?
Well, I can't really comment on budgetary issues since that's not my area of expertise. I can comment on the funding issues, and certainly there are concerns that we don't have enough money, and that is impacting us now and it's impacting the future. At a meeting recently that Senator Ravalia convened, there was a comment about CIHR funding and how much AMR funding was going towards that versus other areas. My take on it is AMR is a global health issue with a really bad marketing plan. We don't have a lot of interest to it, which doesn't lead to a lot of broad support. And the problem is when we don't support research right now, we don't get research right now, and we don't get trainees who are going to do the research in 20 years. Because why would you go in AMR if it's not funded when you can go into cancer research when it's funded and you see a career?
Sorry for interrupting. Time is up for Mr. Ho. Maybe we'll come in the second round. Now we will go to MP Rana for 6 minutes. Please go ahead. You have 6 minutes.
Thank you, Madam Chair, and thank you all the witnesses spending your quality time with us. My question is, Dr. Weiss, to you. do you think Canada is playing its due leading role among the world nations in AMR research?
AMR research is such a broad area, it's difficult to answer that. I would say Canada has some very strong individuals, some very strong groups that have come together. Those have very good international recognition. From a more coordinated aspect, I think Canada gets less attention now. In my work in the global stage, we don't talk about Canada as an entity coming in. They started off some really nice programs. CPARS was mentioned before. This has been highlighted for years, but CPARS has kind of lost ground because it's got a small number of excellent people with less money doing as much as they can, where other countries have taken that on. So from a research standpoint, we have a lot of very good activities going on with some very good people. We don't have the coordination and the international leadership that we would have had in the past, I don't think. That's my perspective, and I've got a very narrow view of the situation, though.
Thank you. Any obstacles you are facing in research here in Canada?
Well, I think obstacles, everything comes back to money, but it's true. Funding is a challenge because funding drives action. But that's one. We have a very collaborative system in Canada. We have people that work very well together and get along. We have a lot of opportunity there. We need to figure out ways to support that. We need to figure out ways to get better access to data, to comparable data that may be siloed or just not accessible. We need to foster international work. And we need to be able to get data that we can use to answer questions that can have action. There was a good example the other day about beef cattle and antimicrobials. We use it a lot more than they do in the US. And why? We need the data to say why, because then maybe we could have an impact there. There are some reasons why it might be justified, but probably we're using more. So if we have better information, we have the people to act, but we need the information to be able to act.
And thank you very much. And do you think like a private and a public partnership can play a vital role in research?
Potentially, but I think the problem with AMR is the public side is a harder draw because there's not as much long-term economic driver. Use antimicrobials less, keep people healthy, keep animals healthy. That's not as appealing, I think, from many public side. Vaccines, obviously, some innovations in healthcare, obviously. But that's a bit of a barrier, I think, because we don't have as much of a broad tie into industry and economic input.
And my question is the same question, Genevieve, to you. Any obstacles do you facing here in Canada in research? Any obstacles?
Thank you. So I'm not as involved in the research sector as some of the other panelists that have spoken, but I would say in terms of antimicrobial stewardship research, which would be my primary area where I've had experience, I think there is a lot of small pilot type research ongoing coming out of individual hospitals or jurisdictions or provinces, and there is certainly not the infrastructure in place to be able to scale those up when we have successes in one area or one institution and kind of realize some of those benefits across the board. So I think more kind of coordination and help with knowledge mobilization once research is done would be very, very beneficial in the stewardship sphere.
And when we compare the Canadian network of hospitals to international examples of antimicrobial stewardship programs, where does Canada's performance stand out?
So I think Canada has been an early leader in antimicrobial stewardship in the hospital sector early on, and I think we need to continue with some of that momentum. In all of our Canadian hospitals, there is in order for them to be accredited, there is a required organizational practice for them to have an antimicrobial stewardship program that is monitoring data with respect to antibiotic use and resistance, and actively working to optimize these things. So that type of kind of high-level national regulation has really allowed for funding in hospitals for stewardship initiatives and efforts to combat antimicrobial resistance. So I think we have, to some degree done well in the hospital sector there and may need to invest more and work more towards expanding that to things like long-term care and community or primary care practices.
Dr. Rees, how would you describe the evolution of global research in antimicrobial resistance over the past decade?
It's broad. I think it's one of the challenges of the complexity because it involves so many sectors, and even within the animal and the human health sectors, it's really variable. We'll see some places where we've had much good improvements in research and coordination, and that's sometimes been at the expense of others. So I think we're probably not improving as much as resistance is increasing.
Thank you. Thank you very much. So in 2018, the House of Commons Standing Committee on Health published a report addressing the growing threat of antimicrobial resistance. Among its key recommendations was the need for stable and adequate funding to support research and innovation in the area of antimicrobial resistance.
Your time is up, MP Rana. Your time is up. Okay. You can complete your question and then we can maybe
so
they can...
which research domains in AMR are most underfunded or overlooked in Canada? You can send us in writing.
Yeah, time is up for MP Rana. Maybe if you can submit a written answer to this question, it would be great. Now we will proceed to MP Blanchet-Jonca. Please go ahead. You will have 6 minutes.
Madame la Présidente, première question va être pour Dr. Weiss.
My first question is for Dr. Weiss. In the last years, Quebec was welcoming many pharmaceutical plants and closing some labs. There were talent went away, and we felt it during the pandemic. We were entirely dependent of international actors for the supply of medication and vaccine. So how can we avoid such a situation happening again, and how can we reinforce our scientific and industrial autonomy?
The first part of the question didn't come through. I got the last part.
Aussi, Dr. Weiss, on semble éprouver beaucoup de difficultés techniques aujourd'hui.
I'm sorry, we seem to have a lot of difficulty with the interpreters. I'm going to repeat this, please. Can I repeat the question?
Oui, je suis habitué.
I'm used to this. I can repeat again. So I am going to repeat again. This last few years, Quebec used to welcome many pharmaceutical companies, but they ended up closing plants and they firing a lot of researchers. So talent went away, and we felt this during the pandemic. We were completely dependent of international actors for the supply of vaccine and equipment. Canada was the only country in the G7 not to produce its own vaccine. So how can we avoid such a situation from happening again? And how can we reinforce our scientific and industrial autonomy?
I'd say that's largely out of my area of expertise, but I think it also speaks to the need for national coordination. What do we need in all sectors? And can there be synergies? If it's vaccination, can we think about vaccination across humans and animals? Are there some that were best left for other countries? What do we actually need to do in Canada to have minimum competency? And what are our options and the safety of those options, the security of those options for outside the country? So like I said, that's outside of my domain, but I think it speaks to the need for a national coordinating program approach.
Merci. Je poursuis vers vous. Donc, vous dites...
I will continue with you. You said that we must finance research now so that we can form the searchers of tomorrow. And this is the same problem we see with all government. We're not attacking the source of the problem. We try to have measures that are really half measures. Do you think that international organizations should finance more searchers in the area of antimicrobial resistance?
It would be nice, but I think internationally we're seeing less coordinated funding. The UK has been a very strong supporter, and funding has decreased from there. AMR is such a broad issue. We need to have an international coordination, but we don't have a logical international funding body. It's in our best interest to put in as much money as we can, and disproportionately, I think, for a high-income country, because, well, for a few reasons. One is we need to make sure that we're supporting research internationally, but infectious diseases that develop overseas impact us, and that's human and animal. And from an animal side, food safety and food security, if a country doesn't have that, there's not human safety and human security. So I don't think we can rely on international funding. We can rely on us coordinating with international groups with funding that we can bring as a Canadian component, but the international community is not going to fund Canadian research.
Merci. Vous dites bon, qu'il faut avoir une meilleure coordination à l'échelle internationale. Le Québec a pris les devants, lui, notamment en interdisant depuis 4 ans l'usage d'antibiotiques.
For the last 4 years, we've been using class 1.
There seems to be some issue.
Yes, they're not translating. That's the issue. There's no technical issue. It's like
Can you please explain?
Okay. Well, if you may, if you authorize me, Chair, it's not a technical problem. I think the interpreter has to think about the word he just heard because it's scientific terms. So there's maybe a delay in that.
So please repeat your question. Go ahead.
Est-ce que vous voulez bien?
Madame la Présidente, j'ai pas compris ce que le greffier.
I didn't understand what the clerk just said. I'm sorry.
It's not a technical issue. It's only because it's very technical terms, so it takes them some time to do that interpretation. So it's not a technical issue.
Donc j'emploie des mots trop savants, c'est ça?
So I'm using two $5 words. Am I using too many complicated words, it seems?
Je vais poursuivre, Madame la Présidente. Écoutez, c'est un peu difficile pour moi.
I'm going to continue. It's difficult to understand how much time I have left in front of me right now.
Docteur, oui, je poursuis vers vous.
Okay, so I'm going to continue with you. Thank you for your understanding. You have talked about international coordination effort, and in Quebec, we have taken leadership in this, and we've had no class 1 antibiotics allowed in agriculture for the last 4 years, and we have an approach that has been adapted to local realities and has given us good results. I'd like to understand how we could have a more standardized approach without this being to the detriment of the leadership that we have had in Quebec up until now.
Well, I think the standardized approach would be using successes like Quebec as the aspiration for the rest of the country, not trying to bring everyone back to the middle. Quebec has taken the lead in those areas, as you know. There are differences in different livestock sectors across the country, so you can't automatically replicate Quebec, but you can use that as a demonstration that, yes, you can do this in many situations if you do everything else right. And I think that's the key, is it's such a broad problem. So we can use this, if there is national coordination and national motivation, we can use this as an example of what we can try to get the rest of the country to. A problem was mentioned earlier, as you know, that veterinary medicine, drug access, health are provincial. So it's difficult for the federal government to mandate something, but the federal government can provide support so that we can get the national networks together to use successes, and Quebec being one. This is done here. How do we get everyone else to do that? Part of it needs to be better communication and collaboration with industry, though, too. And this comes back to hesitancy when vaccination. This comes back to working with farmers. You need trust. And you need two-way information exchange. You can't go to a farm and say you're going to do this because they do it in Quebec. That probably won't go over very well. If we build trust, we build infrastructure, we bring in support mechanisms to let them improve their practices, that's how we'll do it. And that's why it's not just a matter of saying, here are Quebec's approaches, we need to do this everywhere else. We need to build the foundation so that that can be done, build the communication, but obviously using the success in Quebec as the starting point.
Merci beaucoup.
1 minute 20 seconds.
Merci beaucoup. Docteur Sauvé, vous travaillez directement.
Dr. Sauvé, you work directly in the field where you see AMR. How is the lack of financing for the management of this is leading to not enough best practices in the different institutions?
Thank you for the question. So I'm not sure I can comment specifically on the financing piece, but I would say that AMR is definitely having an impact on the front lines. So certainly the clinical impact is apparent, and we are seeing more patients with resistant infections. And what that means is that They may not be receiving effective treatment in a timely manner, which translates to worse patient outcomes. They may be having to rely on second or third line drugs, in which case many of these have more side effects that are harmful to patients and that are also costly to the system. We also know that AMR can contribute to things like longer hospital stays, which again kind of compounds the issue. Exposing patients to more time in hospital is not good for them and not good for the system either. So we're certainly seeing these impacts directly on the front lines. It's definitely not something that is, far away or a future problem, but something that is already having an impact day to day with what we do.
We will now proceed to MP Baldinelli for 5 minutes. Please go ahead. You have 5 minutes.
Thank you, Madam Chair, and thank you to the witnesses for being with us today. Dr. Sauvé, you spoke in your opening remarks to 1 in 4 infections are now resistant and the financial burden it now places on our healthcare system. We had on Monday Dr. Castengay, who mentioned it cost the provincial healthcare systems between 1.4 and $1.8 billion in 2018, and this could grow to $21 billion by 2050. And when you see that type of number, I mean, it leads to the question, like, how does one tackle that? I mean, just think in the province of Ontario, they're spending $80 billion on healthcare spending. It's projected to grow to $100 billion. Right now, the federal government is spending only $52 billion on healthcare for the entire country. And they're projected to spend $68 billion just on servicing our debt. Now, that's not money going to healthcare. That's not money going to healthcare research. That's not money going to the provinces so that they can get additional spaces to train doctors and nurses. And, even as part of the tri-council agencies, the Canadian Institute of Health and Research only spends about $1.2 billion. And now the government is saying to its governments, departments, and agencies, please find efficiencies and savings about 15% over the next 3 years. So in terms of how that is going to impact the healthcare system, I mean, does that not concern you? I mean, in a hospital setting, what do you think the impact is?
Yeah, so certainly in the hospitals, we're always worried about reduced funding and what that means for health professions, jobs, as well as the care that patients are receiving. I think that with the we're very used to in the healthcare setting to trying to find ways to implement cost-effective or cost-saving interventions. And I think some of the other panelists have really highlighted that investing in some of the preventative strategies to minimize the burden of infections in Canadians is actually not only good for their health, but also can lead to cost savings down the road. And a lot of that is very similar when we think about AMR. A lot of these preventative strategies or even stewardship strategies, which I'm more familiar with in the hospital setting, there is literature and evidence that shows that having antimicrobial stewardship programs and certain interventions can actually save the system's money. So I think it is certainly, like many other things, a scenario where sometimes you do have to invest the money in order to find the savings. And we need access to good data about resistance and cost so that we can actually measure how effective interventions are and look at that from a cost-benefit analysis too.
I just want to go to you, Dr. Weiss, because you did say in your remarks, I mean, you talked about the need for better and actionable information and funds to implement some of the recommendations that came from the Pan-Canadian Action Plan on antimicrobial resistance. I think we called this study just so that people want to hear me not pronounce that name correctly. But do you have concerns there as well? Particularly when it comes to the research funds and how it impacts from an animal care perspective?
Well, obviously we have concerns about funding because we don't have enough to do what we want to do. And I think the other issue we have is we try to do interdisciplinary work. We don't have systems that are set up for that very well. We have NSERC that looks at the animal, the engineering, the agriculture side. We have CIHR that looks like the human side, and they like someone else to deal with the interface.
The briefing notes prior to the study, you find that there are about 14 agencies and government departments that are all involved in studying and have a portion of looking into an action and taking action on AMR. And this notion of need for better coordination. So how does that take place? I mean, that's a lot of work that needs to be done to break down silos. Would you not suggest?
Oh, absolutely. Because we know when you have too many people involved, it's too easy for everyone to say it's not their problem. And we see that with funding. And I think we see that with agencies is they don't see it, the direct impact or the direct action step for them. So it's easy to step back and wait for someone else. And again, that speaks to the need for national coordination that can work across those silos, federally, provincially, territorially, locally, within academia and industry, so we can actually get action.
Thank you.
Thank you. We will now proceed to MP Jessic for 5 minutes. Please go ahead.
Thank you, Madam Chair, and thank you to both our witnesses this afternoon. You've both emphasized prevention and the need to reduce the use of antimicrobials. Dr. Sauvé, I'm aware of some of the work you've been doing with faculties of pharmacy to educate students in the faculty to become more aware of antimicrobial resistance. But there are a lot of existing pharmacists out there. Do you have any ideas of how we could perhaps continue this conversation more broadly with pharmacists in general, in other settings? I'm thinking long-term care, perhaps, where there might be more of a team approach between the physicians and the pharmacists involved in the care of seniors in long-term care. Could you tell us a little bit about your work in terms of trying to improve the awareness of AMR that you've been doing and how you might see it being extended to other sectors?
Yes, thank you. So the work that I have been doing is on developing a curriculum framework for pharmacy programs across Canada in order to enhance their education on antimicrobial resistance and antimicrobial stewardship so that our next generation of pharmacists are not only aware of this issue, but have the skills and the knowledge that they need to be able to impart change. And I think what we really know is that those of us practicing in this field, we can't do this alone. So it can't only be infectious disease specialists or, pharmacists who specialize in this field, but we need all healthcare providers to be engaged and to be working on these in their respective areas. So I think there is a lot of opportunity to take some of the competencies for graduating students that we've developed in the pharmacy curriculum, and I know other professions have been working on this as well. And, may need some minor tweaking, but be able to expand these more broadly to pharmacists who are currently practicing and target education and training initiatives for those practicing pharmacists or other practitioners. We also need to think about this in terms of many of the healthcare professionals who are trained in other countries around the world and choose to come and work in Canada. Their education on AMR or the landscape of AMR and antimicrobial prescribing in other countries may be very different than here. So we need also some targeted interventions and some work with accreditation and licensing bodies to make sure that when they come and work in Canada, they do have the training and the support that they need to be able to contribute to this effort for antimicrobial stewardship and resistance here. So I think lots of opportunities there. I will say one thing that could be useful in long-term care and in community where stewardship has traditionally been lagging behind for pharmacy. So my role as a stewardship pharmacist is almost exclusively only in hospitals at the present time. So if we want to have healthcare providers in these other areas like long-term care and community engaging, we do need some leaders to be in those spaces and help with training and education. And currently we just don't have those positions that exist.
Thank you. Dr. Weiss, you have commented on the lack of surveillance data as when it comes to the use of antimicrobials and antimicrobial resistance in the veterinary area, and particularly you mentioned pets. How would you see in a practical way that we might improve that surveillance? What is needed to get the kind of data that we require?
It's difficult, and that's one of the challenges, and it varies across sectors. As we have improvements in technology and more computerization of every system on farms, veterinary clinics, it becomes possible, or at least more possible, with support. And I think we need to look at, again, big picture. Some similar challenges are there in the human field, in communities and in dentistry and everything else. I think we need to look at, this is one where the One Health approach, let's try to do something that can address all the problems, would make sense as opposed to a siloed activity. That said, we have a lot of things that are different between farms and pets and different sectors. So we need to get better data, and there's not one way to do it. We get pharmaceutical level data for animals right now, but that's largely at the tonnage level, which doesn't frankly tell us a lot. It gives a soundbite number, it doesn't guide us in action, and doesn't let us monitor response. We have to figure out ways that we can get individual animal level data or farm level data, and part of that I think ties into the previous questions, improving trust.
Thank you. We will now proceed to MP Blanchet-Jonker for 2.5 minutes. Please go ahead.
Merci. Donc, Dr. Sauvé.
So, Dr. Sauvé, Canada has adopted the One Health approach, but many provinces and Quebec have integrated structures between health, environment, and human and animal health. Should we be financing the provinces directly so that they each develop their own One Health strategy, or which are something that is
Uniformisé.
got to do with their own reality, or should we have a standardized national approach? What do you think?
So I can't comment so much on the other sectors outside of human health, but I would say regardless, a national coordinated approach is needed to address antimicrobial resistance. And as everyone else has highlighted, bacteria don't respect borders or provinces or territories or jurisdictions. So if we really want to have valuable surveillance data and we really want to be able to enact broader change, I think that national coordination is essential.
Est-ce que vous avez des suggestions à...
Do you have any suggestions to make as to the system? Because the system is not uniform across Canada. There are different specificities, geographical, demographic, etc. So I understand that microbes don't respect borders, but how do we do that if the reality is different from one place to another?
It's a good question. I think it's a hard question. I think that we have to understand that you're right. The reality is different everywhere, and a cookie cutter approach is not going to work in every setting. So I think we still need that national level leadership and bringing people from the various provinces, areas, sectors together so that they can speak to what will work or what might work in their respective area and field. So we still need that forum and coordination of resources because there are inevitably going to be many similarities and commonalities between, but also those voices from each area in order to respect the differences and tailor approaches to the local culture and context.
Thank you. And now we will have MPD Ryder for 3 minutes, and then we will end the panel with MP Rana for 3 minutes.
Thank you, Madam Chair. I'm going to ask Jenna the question to you. You mentioned that there's a misuse and overuse of antibiotics is contributing to the antimicrobial resistance, and part of that is misdiagnosis. We know here in Canada that there's an extreme lack of doctors. In Canada, we're not only losing our doctors to what we call a brain drain happening because of the tax burden, because of affordability, all the things happening in this country, but also we're unable to retain or we're unable to attract that talent as well, again, because of the tax burden, affordability, housing, and things like that, coupled with the fact that I've actually met a taxi driver that is a doctor in this country because of the educational barrier to get licensed here in Canada. So do you think that all of these constraints for us to not have doctors in this country is actually a burden to the doctors, and it's leading to misdiagnosis and overuse that's happening and contributing to antimicrobial resistance?
Yes, thank you. I think I think definitely the strain on the healthcare system and likely primary care in particular does definitely play a role in the overuse of antimicrobials and antibiotics. So we know that we do have a shortage of primary care physicians, certainly in Ontario where I practice. And what this means is that patients may not have, or physicians may not have the the time available that they want to spend with each individual patient. They may not have the opportunity to follow up on patients after that initial consultation. And in some cases, there may be a notion that prescribing, antibiotics is a bit of a safety net if we're unsure whether infection is playing a role in the patient's presentation. So that diagnostic uncertainty is something that we struggle with a lot and is certainly compounded by, a lack of healthcare providers or physicians and the time that they're able to spend with patients. So I think that to answer your question, yes, that certainly plays a role. We need access for primary care for all of our, all of Canadians, and infections are such a common syndromes that are seen day to day. So any gaps in primary care are going to trickle into the system and contribute to AMR.
Thank you so much. I'll just use the last couple seconds here to thank all the panelists for coming today and joining us. Thank you.
Thank you. We will now end our panel with MP Rana for 3 minutes. Please go ahead.
Thank you, Madam Chair. Again, back to you, Dr. Weiss. You have argued in your work that whenever antibiotics are used, resistance is generated to some degree. So in Canada, how big is the trade-off between access to antibiotics and overuse stewardship?
Access from the animal side, there have been great strides made in the last 20 years. So antibiotic access is going through a veterinarian. So that has been a big advantage, and one that we have over other countries where there's over-the-counter access to it. So we have a professional gatekeeper. There's still overuse for various reasons. So we've addressed one major loophole, and we have many more to address. I'm not sure if I can really answer that question more than that, but we have other areas to address to reduce.
And what mechanism could the federal government implement to enhance collaboration among post-secondary institutions, healthcare providers, industry stakeholders, and public health organizations engaged in AMR research?
Well, obviously finances, but I think a coordinating system, money put into a coordinating system would be we'd have a better return on investment than money thrown at individual efforts. So a stable, long-term, sustainably funded network that can tie in all the relevant parties, build on that expertise, and make a sustainable, decades-long program would be my goal.
Okay, and again, in the last few seconds, I will say thank you very much. We asked too many questions to you. Thank you. Thank you.
Okay. So with that, the panel comes to an end, and I would like to thank both the witnesses. I think Jenna's survey is frozen, but thank you to both the witnesses for appearing before the committee and providing your important testimonies towards this study which we are doing. So is it the will of the committee to adjourn the meeting? Yes. Okay. So the meeting is adjourned.